Good morning, everybody. Welcome to our 12th webinar of the year 2021 and the second day of California's grand reopening of the economy. I still find it hard to believe that it's been 15 months since we started meeting like this and our personal lives and our work lives changed so dramatically, yet here we are beginning to see some things return to normal or feeling like they can return to normal at some time in the future. And that's, I know, a mixed feeling for many of us. And we're going to talk a little bit about this during the webinar today, but vaccinations have surely been the key, and you all have done a terrific job of supporting your participants, your families, your staff, and getting vaccinated. Thank you, Science, for getting us to this point. Thanks to you guys, and thanks for joining us today and being part of this virtual community over the last 15 months. It really has been something. And I enjoy being here to support you with all of my colleagues that you'll meet today, some of whom you have met actually many, many times. So I wanted to let you know we have about 400 people coming on. People are still signing in. I can see we're at about 230 right now. And as always, you know, I'm Lydia Missilidis, the Executive Director of ALE, your host for these webinars, and these are, of course, made possible through the generous donation contribution from Archstone Foundation. And that will continue through September. Danielle, thank you for being here. Next slide, please. So you know the drill. We're being recorded, listen-only mode, handouts. You can grab 2 handouts from the Handouts tab to the right of your screen on the control panel. The chat and hand raise features are off, but we would love to get your questions in the question box. There will be a survey at the end. Please complete it. Send in questions, comments. We love to read them. We do read every one of them. And I want to thank Danielle for helping out today while Pam's on a 2-week deserved vacation. Next slide, please. So as always, we like to share the evaluation from the prior web talk. This one also had to do with getting back to congregate services. Today will be a little bit different take, and we're going to have a bit more time for questions. 4.7 was the evaluation, and 54 questions came in. We had a lot of behind-the-scenes support last time to answer questions, and about 75% of them got answered either live or in the question box. So thank you to all of you who helped with that, and thanks to those of you who sent in those questions. Next slide. So our panelists today will sound familiar, look familiar, and they are familiar to you because they are part of the Vision team who've been meeting weekly since March and continue to meet weekly, sometimes twice a week. So I want to thank all of you from the panel for being here today and sharing your experiences and your thoughts. This group is sort of like the advanced scouting team that goes out and looks ahead and then reports back to all the rest of us and helps us find our way through this COVID thicket. Next slide, please. So here's what we're going to cover today. We promised we would talk about the reopening, and we are, and guidance, and we are. There will be some disappointment because it won't be as clear as we would like, but we're going to keep at it and keep sharing with you guys as we learn things. And then talk a little bit about what does apply to y'all right now, what's ahead for July and August. We're going to talk again about evaluation, reassessment, and planning because we can tell from your questions and calls and comments that there's still a little bit of fuzziness around that. We're going to have panelist time and then our usual closing. So thanks again to my panelists for being here today. Next slide. So as I mentioned, we are disappointed that we don't have specific guidance that we have been hoping to have for you from the Department of Social Services, Community Care Licensing, and from the Department of Public Health for our CBAS ADHD programs. We do understand it's in the works. Jill is here, Jill Sparrow from CDA, to talk a little bit more about that and what we might expect. But as soon, the moment that we have that guidance, be sure that you will also have it in your email boxes, inboxes. So I want to let you now hear from Jill, and she's going to do the best she can to share what she can. And I just have to say, everybody, as always, there are a lot of questions that we may not be able to answer directly today, but please still send them to us. It actually does help us out when we know what's on your mind. So Jill, thank you so much for joining us again. As always, you've been such a reliable, great partner through all this. And we wish you, all of us, I think, wish you a very good vacation, a well-deserved vacation coming up in July. So we won't see you for a little bit, but.
Yeah, well, thanks, Lydia. Yeah, it's great to be here, and happy to be talking with all of you again. And like Lydia said, I wish we had more concrete information to share and more news. Feeling like we're coming somewhat empty-handed, but know that more guidance is on its way. Again, we're just in this temporary period of time where kind of a holding pattern where we're waiting on more guidance, anticipating a release soon from a few different sources. And one of those sources, of course, is the Department of Public Health. And we know that right now they are working on some additional guidance specifically for ADHD providers, CVAS providers. And it's right now the guidance they're working on, it's going through internal review. And we're looking forward to the release of some additional guidance that we anticipate will speak to vaccination, masking, distancing, transportation. We anticipate and hope that that guidance will be released very soon, but we do not have a release date quite yet. In the meantime, because again that you all operate healthcare facilities, make sure that you continue to follow the guidance that still is in place. In addition, you're probably all familiar and all know of the public health order that was issued on June 11th that applies to the general public. And this now allows the general public to, for fully vaccinated people to go out mask-free in some public places. But this guidance was also very specific, where it did call out particular areas, locations where this particular guidance did not apply, and those in particular were healthcare settings, which includes ADHD and CVAS. So that mask-free, places, that guidance that was issued on 11th doesn't apply to ADHD, CVAS, nor does it, apply to public transportation, long-term care facilities, schools, other youth settings, and the cooling or emergency centers, shelters, and correctional and detention centers. So again, while this the health order was, I'm sure, welcomed by all of us, definitely we know we still are waiting on guidance specific to our setting, ADHD, CVAS. The guidance also indicates again, unvaccinated people must continue to wear a mask in all public indoor settings. And indicate, businesses may ask for vaccination verification from individuals. And just to note, you can, as a provider, require everyone to wear a mask in your center, regardless of their vaccination status. So that is, again, still you have the prerogative to do that. Just again, and speaking to ADHD, there are additional rules for adult day programs. They have their own specific guidance, and I believe the next slide talks a little bit about the upcoming guidance from them. Next slide. Oh, sorry, one more teaser before we get to adult day programs. Cal OSHA. We are waiting on and anticipating guidance to be released soon from the Cal OSHA Safety and Health Standards Board. They've been working on updating the workplace guidance and the regulations. We anticipate we'll see something this week, tomorrow, and that guidance would be taking effect at the end of June. So again, until the release of that new guidance from Cal OSHA, remember that the current emergency temporary standards from this past November are still in effect, and that a COVID prevention program is still required as part of your illness and injury prevention program. And you'll just see some contact information there at the bottom of your screen if you do have any questions about that. I mentioned earlier adult day programs. And we all know that Department of Social Services Community Care Licensing has been releasing guidance on a regular basis regarding adult day programs. We anticipate more guidance to come from them. They are currently working on something, which is going through an internal review, and we are looking forward to provider information notice to be released soon. And typically that's usually followed by a training webinar by DSS. So lots of information coming down the pike. I think we're as eager as you are to get our hands on that new guidance. And of course, CDA will be, working on updating our guidance as needed in the upcoming weeks and months. Next slide. I think this is where I'm going to hand it back to you, Lydia. Thank you.
Thank you, Jill. And Jill will be with us for the duration of the webinar and will be able to help us with questions as needed. So thanks so much, Jill. Appreciate that overview. So we've been using this Ready, Set, Go theme now for the last few months, courtesy of Jennifer Payanessa, who's on the vision team. And what this says to us now, we've kind of passed the ready stage. I hope most of you are. You're feeling like you're getting things set up for resuming congregate schedule as you safely bring people in to evaluate them or assess them or reassess them. And you're following the safety protocols to do that. We know you're all moving at your own pace. Every center is different. Every group of participants is different. ADPs, ADHCs, all the other alphabet soup out there that we all know and love. And I just want to say I am excited to begin hearing from some of you about your successes in bringing people into the center. And actually, some of you have begun bringing small groups in. So I'm really happy to hear that. We want to hear more from you all about how that's going. And we're going to set aside some time in August to share those successes and that journey to return to congregate services. We know it's been a long, hard year. We need to stop and celebrate once in a while with our successes. So with that, setting the stage, I hope, will be Richard, who all of you know. He's been a regular on these panels, and he'll talk to us a little bit about kind of where things should be or are today, and then we'll move on to our next segment. So Richard, welcome. Glad to have you back.
Thanks, Lydia. Hi, everybody. My name is Richard from Beverly Adult Healthcare in Los Angeles. I'm the program director here. And like Lydia said, I'm just going to provide a bit of a brief overview again of where we're headed, where we should be, what we should be thinking about. And then some other providers are also going to come on and give you a little bit more detailed information from their perspective. We want to talk about, again, what Jill just mentioned in terms of the guidance and how it applies to us in adult day services. On June 15th, everything was considered reopened. But again, we know that this does not apply to our setting, which is healthcare settings. For ADPs and ADHCs, it's a little bit different because we have CDSS and CDPH putting out specific guidance in the future regarding distancing transportation. And so for the time being, we know that the general public population is very different from the population that we serve. We have to also consider things like liability. And so not much has changed just yet for ADHCs and for ADPs, but we just want to make sure that we're grounding our reopening and kind of our programming right now in the universal truths that we are always talking about, which is the distancing and the masking that is in place. Next slide, please. Which means that until further notice, we still have to abide by all the things that we listed in Form 7027 and all the things that we know, which are standard, maintaining 6-foot spacing inside the center and within transportation, and still maintaining face coverings when indoors, regardless of vaccination status. I think we want to make sure that we are prepared to adjust when the guidance comes out, but at this time, we're still doing the regular things like hygiene, cleaning, screening for temperature and signs of infection, using outdoor spaces, ventilation, everything that I think centers have really run through their heads prior to June 1st when we were required to submit the documentation. Next slide, please. And I think this brings us into kind of reiterating how important vaccinations are, because we want to make sure that if there is guidance that differentiates how services can be provided or how we can be transporting participants that are vaccinated versus non-vaccinated, then getting our participant pool to 100% vaccination or as close as possible is really the easiest way for us to operationalize any changes. And so I think everybody's done bulk of the work toward the beginning of this year in getting all their participants vaccinated, but we know even for ourselves, we still have a few holdouts, a few people that were really hesitant on getting the vaccine. And so maintaining that, again, going back to the MyTurn website that we were talking about a long time ago, there have been a few changes and a little bit more options in terms of having people able to come out to individual sites or homes to be able to vaccinate people who are not mobile. And one thing that we found, especially even this week in vaccinating one of our participants that was very hesitant, was we reached out to the pharmacy that that person, gets their medication from and found out that they were providing vaccinations on site. And so it was a very easy, clear link to be able to just recommend the participant to go to someone that they trust, a provider that they trust, to get the information and get the vaccination. And we're now one step closer to 100% vaccination, and which is always a challenge, but we want to make sure that a lot of places, no appointments are needed. Neighborhood pharmacies and retail pharmacies are now almost always fully stocked. And we also have the additional option of Uber and Lyft rides being free to individuals that are requiring vaccinations. So if you take that extra step and really as a program director or administrator, take those things into consideration, it might be much easier to now, rather than a few months ago, get participants vaccinated. Next slide, please. We also want to acknowledge not just ADHCs, but adult day programs and regional center funded programs as our partners, and that different programs, like Jill mentioned, are at different places and different states in programming. I know there are some adult day programs that were open since last September. And so I think it's very helpful for us to pay attention to each other and borrow lessons learned, because everybody's a valuable partner to each other because of this kind of fluctuating time. And again, just to reiterate that each sector has their own guiding entity, CDPH, CDSS, that will prescribe specific guidance. But at the same time, if there are centers or if there are programs that are moving ahead in a safe way, there are a lot of things that we can learn from each other. Next slide, please. And so this kind of goes into the real world. Okay, what's happening now for CVAS centers and for adult day programs? And we know that we're continuing and resuming now in-center services, and that we have started the reassessment processes for the July starting TARS, and that evaluations are happening for people that are coming prior to the reassessment period. And so I think that's kind of the takeaway of everything that we've been saying over the past few months, is that these things have to happen prior, and that this should not be done at the last minute, because although the timeline is October 31st, in that the last day that we have to have everything ready, it's going to take much longer than that. And I think we have to conceptualize and make changes prior to deadlines. And we all agree that it should be now rather than later. And for adult day programs, again, they have not been ordered to decongregate. And so we have a lot of lessons to be learned from that sector as well. Next slide, please. We just want to refer back to this timeline, and we'll move the circles as we get, progressing throughout the months. But we can see now that we've had a lot of time from April to June. We've already been basically 3 months in since the ACL came out, or 2 months in since the ACL came out. And so we were planning in the planning phase, the ready, and now we're moving into the actual action phase of having to do the reassessments, quarterlies, evaluations all together at the same time. And so we're really in the thick of it. And although a lot of time has passed, we have a lot to do and to get toward until we reach that October 31st deadline. And so I encourage all program directors, administrators, all operators, and staff members to really not wait until you kind of run into that wall of October 31st, because all these things in conjunction will, again, take a lot of time. Next slide, please. We want to reiterate again that the deadline to resume congregate services is October 31st. But if you wait till the last minute, you're giving yourself essentially less time to adjust to the changing environment. In my mind, it's kind of like waiting until the last minute to write an essay and then finding out that your printer's jammed or that your computer needs to reboot before you turn it in. If I wrote the essay ahead of time, it'd be much easier to solve problems. And we all know as program directors and administrators and staff members that nothing in ADHC goes according to plan. So really starting ahead of time is not just common guidance, but it's actual real world problems that we're trying to avoid. And we also know that these public health emergencies will end and that these flexibilities will end. And so we know that alternative services will go away, therapy hours will come back, return to core services as much as possible, and that we know that hiring is going to be a challenge. And so we encourage everybody to really take a step forward and fully staff and kind of fully get their processes back into pre-COVID kind of ways of doing things as fast as possible. And we want to kind of, as an industry, really focus on our unique status among providers in long-term services, and that is that we provide congregate care, and that's our bread and butter. If we are fixated on doing task services, then we're not any different than the other kind of realms of long-term services that are out there. But the reason why we exist and the reason that we have to exist is because we are providing care in a congregate setting. And so I think that should be our ultimate goal, even throughout this transition process. Next slide, please. And that brings us back into kind of the tasks of what we're doing right now in terms of operationally what we should and should not be doing to allow us to kind of move forward through this process of June through the end of October. And I think just best practice is not enrolling more participants than you can safely serve. Just mathematically, although we're scheduling people for one time a week and we're allowed to stagger schedules, I think that we know that the eventual goal is to have everybody move to congregate. And for centers that have higher utilization or a little bit difficulty with transportation and kind of operationalizing things, enrolling more participants may not be the best way to do these things because there's so much more additional documentation that is required. We also want to address the fact that participant statuses might be different. They might be worse than during COVID, or they might be better. And depending on the conditions, we're going to have to readjust their schedules and kind of their frequencies as well to make sure that their medical necessity is documented and that we're providing appropriate services. And so I think the last thing we want to do is have someone discharged that needs services. But if we can prevent that by adjusting the services down or up as needed, I think that's a very good practice for us to do. We also want to obviously not just talk about nursing and social work as the core services and activity, but know that the skilled therapies, and as soon as we can have them back, is really going to be a valuable tool to regain the strength and stamina of the participants when they're returning. I think everybody knows that rehab services and maintenance services is going to be one of the primary ways that participants will be more mobile and able to attend more services. And so those are definitely just really good things that we have to keep thinking about. And also scheduling out, not just thinking about the month of June, but toward the end of the year. Okay, how are we going to fit in the people that we haven't reassessed by the October 31st date? And really just writing that down and seeing how many people, if it's 5 participants a month or 10 participants a month extra that we have to do in terms of an evaluation or reassessment. Mapping that out with the staff to make sure that you have the staff able to do that is really, really important as well. And then we want to conduct evaluations. The picture on the right is actually from this morning, and I just caught our staff members, MSW, our RN, and activity staff member, just talking about during the evaluation how they have conflicting information, not in a bad way, but if the MSW thinks that cognitively the person is okay, but the activity person recognizes during their doorstep that this person can't really keep up with time. They might not be able to make the bus on time, and kind of reconciling that. And I think that we'll go deeper with the evaluation explanation, but I think this kind of serves as showing how the evaluation is a process in itself and not just a single form that we're going to be using to kind of return to congregate services in a safe way. And so with that, I'd like to hand it off to Kay, and she's going to further review this transition process for us and kind of where we've been and where we're going.
Thank you, Richard. Again, hello everybody. My name is Kay Lee. I'm from Commonwealth Adult Day Healthcare Center in Buena Park, California, in Orange County. So Richard gave a really good outline of some of the nuts and bolts of what we're doing throughout this process of gradually moving towards congregate services. Today I'm going to be talking to you a little bit more about the big picture and some of the broader ideas and principles that we're all seeking to accomplish during this hybrid process as we move gradually towards congregate services. So one of the principles that we are thinking about at our center is what the goals of returning to congregate are, as well as how we can create linkages between the remote services that we have been providing with the more in-person services that we are now providing moving forward. And so again, just to reiterate, even though we are moving towards in-person congregate services, we're still under temporary alternative services. We're still under TAS. And so while there is a lot of different planning and a lot of additional considerations that go into place for congregate in-person services, it's really building upon some of the good information and the good practices and the really important work that all of the centers have been doing throughout the TAS period through remote and doorstep services. And so some of what we've been seeing throughout our process of gradually bringing more and more participants into the center to provide in-person evaluations and assessments is verifying and recalibrating some of the information that we've gotten over the past year and a half through telehealth and doorstep services. Next slide, please. And so you can see here really the focus of I think for our center, and I'm sure for many others, is how we can link together the remote services and doorstep services that we have been doing with the in-center services that we're now seeking to expand over the next few months. You can see in these pictures that are provided, a lot of centers are bringing participants in with social distancing, with masking still in place, and doing evaluations and services that way. But also, as you can see on the bottom of the slide, the impact and the benefits of telehealth services throughout TAS was invaluable. And so really the focus right now is to see how some of the information, the valuable information that we've received over the TAS period can be connected and verified with the evaluation process. So in other words, you may have been getting really good vital signs information from our participants. Some of the focuses of the services that we provided at our centers, especially during the beginning and throughout the middle of the initial public health emergency, was teaching and through education and through providing blood monitors for self-tracking of vital signs. And so a lot of our nurses and staff spent a lot of time in really helping our participants maintain their independence as much as possible throughout the initial quarantine and lockdown period of the pandemic. And so whether it's coordinating with our social workers to get the monitoring devices into the home, and as well as providing education on how to use and track personal vital signs, we found that that was a really effective way of fostering a sense of independence and a sense of self-autonomy for our participants throughout some of the more scary parts of the initial months of the pandemic. And so by bringing in those data points and connecting them with the data points that we're able to gather through the evaluation and assessment process in the center, we're able to see, oh, this participant's been really good at monitoring their symptoms and reporting it out to our staff. Or on the flip side, and maybe this participant wasn't really able to take in a lot of that education, and it provides a really good jumping off point to reevaluate and change up the care plan as necessary, because we have more options available to us through in-center services. And so I really think that this goes back to kind of the core principles and the core belief system of the adult day services writ large, is really providing a support system through our center programs in helping to foster independence within the community for our participants as much as possible, regardless of what type of health problems that they are experiencing. And so this is really just kind of a big picture idea of what the purpose of the evaluation and assessment process is during this hybrid transition phase. So next, I would like to pass it along to Diane.
Thanks so much, Kay, and thank you everybody for being here this morning. It's a pleasure to be with you. I'm going to turn off my camera in just a few minutes in order to ensure I have better transmission up here in the rural Northern California area that I'm in. But I just want to say first that, again, thank you to Richard and Kay for setting the stage so well for what we're about to talk about. We're going to go fairly quickly through looking at the concept of evaluation, which in a sense is a new kind of description of a process that we know really well. And as Richard and Kay were talking about this transition back to in-center services, I was really thinking, you know, evaluation is like the bridge that we're going to use to cross from remote services into in-center services. And no matter how extensive the evaluation process is, or whether we're doing formal reassessments, we need to bridge this period of time. So this will help us do so. So we'll start by looking at what an evaluation is. And I want to mention also that what we put together here is intended for your further use in training or as cheat sheets or in any way you need to. And if we get to the end of this section and you feel, you know, we've really got this, or you feel that the whole time, that's just great. So what we're trying to do is just really clarify and layer in information that will make it easier for you to move forward as quickly as possible. So the challenge is that having been in an emergency service mode required us to find new approaches. And when you go to seek terms to use to describe various kinds of things, you know, often it's the same terms that make the most sense. But in ADHC's CBAS, we have really specific uses for certain terms. We think of a reassessment oftentimes as being the full process. And there isn't normally a technical description of what evaluation is. So evaluation was chosen to represent this process of returning to in-center services and getting the information that we need in order to do so effectively. So really think of it as a reevaluation process, because the people that you are doing evaluations on were previously attending in-center. They're not brand new participants. And so you're going back and you're revisiting the information that you have on them and their health status. And then we'll do a set of mini assessments to find out how they're doing and whether they're ready and able to return to congregate services. Again, for people whose TAR is not due, but who want to return and need to return to the center prior to their month of reassessment, when we'll actually do the full formal reassessment process and resubmit the TAR and the IPC. But meanwhile, you do have to have a currently relevant care plan that you can use for their continuing tasks, whether it's in center or out of the center services. And you can't really restart their congregate services until you've reevaluated the participants so that your staff team knows how they're doing and what their updated care plan should be. Next slide, please. So every process has to be developed by gaining understanding of what you're trying to achieve. And this slide summarizes basically what we're trying to achieve through the process of evaluation. It's an important list because the ACL 2104 that gives us our guidance on returning to in-center services calls for these specific things to be addressed. So the purpose of the evaluation is to learn what you need to know about each of these areas, to learn what you need to know before you can schedule the participant for congregate services, because you need to be able to safely serve them in the center for the day. And you also need to be able to address their current needs and medical necessity for CBAS tasks in order to provide services in the center, even 1 day a week. That's always what we should be doing. And in order to be person-centered, to provide the services that the participant wants. Because we can't assume that what they were interested in, you know, over a year ago when everything started is what they need or want out of the center today. And evaluation can be thought of as an ongoing process over a certain period of time. It's not just one point in time. So it's not just one conversation that we have with the participant. It's the set of conversations or the set of mini assessments that need to occur in order to feel complete in having fully evaluated the person. Next slide, please. Evaluation helps you to break the ice, basically, to open up a fresh door, to build that bridge, however you want to think of it in your mind, but to get the information that you need to have in order to be able to safely and effectively serve the participant and address their needs in ways that will improve their health, which again, that's our core goal in this program. So this can include the participants' feelings about returning, their general state of mind, how they're feeling about things at this point, their memory and cognition, transportation and housing needs, new health problems and medications, recent falls or hospitalizations, and the current status of their conditions. This is kind of a cheat sheet in the sense that we are going from shifting from an emergency model of care into, we're still in the emergency, but we're shifting into a recovery phase. So if you think of any disaster, when you start out and you're in the midst of the emergency full on, you have more limited things that you can address. As things begin to recover, then you can get the full picture again. And that's what we're going to be working to do through evaluation or through the regular assessment process for people whose TARS are due. We haven't seen many people in person for more than a year. And so if under any circumstances, whether their TAR is due or not, you feel that you need to do a full assessment process, what you would normally do during a reassessment period, then you should just keep going and do all the assessing and record gathering and everything that you need to do until you have all the information you need to be able to serve the participant safely and effectively. You really want to be able to fill in that other half of the picture. So essentially, evaluation overlaps with the concept of the assessment process. So next slide, please. I wanted to touch on nursing physical assessments for just a moment, because if we think about, what we really have the opportunity now to add to that picture to get the full picture, it's really being able to work with the person in person. And when we're doing telehealth, we have a lot of opportunity to get subjective information from them or from their caregivers. Or even from other people who are working with them. And that subjective information is extremely important, how they are feeling about things or their perceptions of their health. But when we have the participant in the center and we're able to work directly with them, then we can add getting the objective information that we get when we do physical assessments. So whether it's a nursing assessment or an OT or a PT assessment, or even a social work or activity coordinator assessment, being able to see that person face to face gives us a lot of information that is objective and concrete, including just the most basic things like observing their mobility. I think about how often when a participant would, during regular services, come in the front door in the morning, and the staff team would immediately note things physically that had changed. And so the participant would get immediate assistance through nursing, through social work, through whatever department they might need that help through, because we were able to observe their need. And that relates to what we are now being able to add into the whole picture. So we should, really make the most use of that we can. It doesn't mean that you have to do an extended assessment, but we need to make sure that we're really taking advantage of our opportunity now to be in person with the individual and to gather that objective information. Next slide, please. So some key concepts that are helpful, I think, as you look at the requirements of ACL 2104, or as you think about all of this, as you think about what's different about an evaluation from the reassessment process that we do, we always have to assess when it's needed. So whenever we observe changes in the participant, the nursing, for instance, reassesses them, and then we modify their care and their care plans as necessary. We document, our assessment of them, the results of the assessment, and the changes in the care plan. So that's actually, our bread and butter basic thing that we know how to do. And that's really what we're doing in the evaluation process. We're creating a term for that indicates all of the ways in which we might be gathering information, and as Kay described so well, but it's basically what we know how to do. The care plan describes what we're providing for the participant. The care plan with, no capital letters, but the IPC form itself, the DHCS 0020, is the document that we use to submit the care plan for approval. So very often when we say, care plan, we're thinking of that document and we're thinking of the submission. And so in thinking about evaluation, it really helps to think the participant has a care plan and they have information that we gather, and then we put that into the IPC when it's required with the right timing for renewing their authorization, and we submit that for approval. So they are related, but they are not exactly the same thing because the care plan lives outside of and comes before the IPC. Next slide, please. Evaluation right now is a helpful way to prioritize who we're going to be serving first, what we're going to address first, how quickly we should have them resume in-center services, what they're going to need at home at this point in time, because those needs have likely changed as things have opened up in the community. So as we use evaluation to prioritize, everything should be driven in essence by the participants' needs in keeping with our requirements. And we can determine these further areas to address them as quickly as we can, but we don't have to do it within a specific time frame in the sense of you've got to do it on the first day that they come to the center. You can prioritize what you address on that first day. You can go back to additional things on the second day that you bring them in. So again, you can plan that in accordance with the timing that works for the participant, makes the most sense. But if you prioritize essential concerns like, if they're having balance issues as they return, or have had significant medication changes, or are, really having mental health concerns or struggles, you would want to prioritize those and begin to address them as quickly as possible, even if you're not scheduling in-center services. So again, evaluation and assessment are always continuous in CBAS TAS and in CBAS. And the changing needs of our participants are going to require updated approaches, even though the IPC may not be due yet. Next slide, please. So the icebreaker concept, getting back to that, this is a set of icebreaker questions. And I thought of it as in working with participants through telehealth, over the phone frequently or on the doorstep, we're doing our best to get the information that we need at all times to be able to address their deepest concerns. But it's different than having them at the center. When we have someone at the center for a full day, the information that we get about their health comes in all kinds of ways. It may be shared while they're getting assistance with their personal care. It might be, they might ask to talk to the social worker. They might be talking to you during an activity and tell you important things about how everything's going in their life. But in working with them through telehealth, it's a little harder to have that happen because things are a little more constrained. And so the other aspect of that is that because we've been very concerned about making sure that people feel uplifted, that their mental health stays strong, helping them to continue to relax about, the emergency going on. So it may be that patterns develop. For instance, if I was calling somebody regularly and I learned that they really brightened up when I talked to them about their garden, I might keep going back to talking to them about their garden, and we might have a wonderful time with that. But I might not get some of the information about other aspects of their health. So now we're reopening a door, we're building a fresh bridge. We're going to need to break the ice on going deeper. And so these open-ended questions are written in such a way as to be as objective as possible, and should be adapted for your own style. But if you see questions here that are helpful to you, to be able to kind of get out of that pattern that you might be in with a participant, or to begin to break the ice on the things that you need to know as part of the evaluation process, this is a tool that you can use. Next slide, please. And as we begin to bring people back, and we're defining how we want to provide tasks to each participant outside of the center or in the center, both of which are valid and are needed to address continuing needs right now. The getting down to the person-centered level, getting the individual details is of course extremely important in order to be able to link these services. So next slide, please. It's essentially, we're going through the care planning process, and we've used this slide a number of times during web talks since the beginning of the pandemic, that in TASS, in CBAS, in all that we do, this care planning cycle is just built in to the heart of what CBAS is, what adult day healthcare is. We assess needs, so we learn about the participants' needs and concerns and interests. But then we plan interventions, so we don't just get the information about what their needs are, we need to respond. And you can call those interventions, you can call it action planning, you can call it a treatment plan, but you do have to plan something that's going to make a difference to the need that was shared with you. And then you implement that plan, and then you evaluate the results. And the evaluation process is just akin to this. We're now doing that step of assessing the needs of the participant. Then we'll plan the interventions, which is the continuing task services. We'll implement that, and we'll see how it goes. The evaluation process starts all that out. So it's back at the assess needs stage, and then the planning interventions. Next slide, please. And to avoid being generic about that and to be really person-centered, these are, again, just kind of a cheat sheet for areas that we're going to be attending to and fresh ways to think about it. When we're in the center on an ongoing basis, we take vital signs for a lot of people. We take their blood pressures, and we have parameters that we're operating within for when to take further action based on what their blood pressure is. As Kay described, programs have done their best to try and keep that going during this time. But now, as we get people in person, we're able to really verify what their current vital signs are, and we may want to do that more frequently than we had done before they were home for this last year. because we want to make sure we really understand where they are and what has happened with their health conditions. So changes in health and the timing of those changes, and the physicians we need to inform changes in their ADLs or IADLs so that we look at those through therapy, changes in their medical care and the importance of getting their health records and coordinating with other providers, changes in their risk factors, which we've been trying to watch the entire time, but we now need to see how well we were able to really see how things were progressing for them and where they got to. It's interesting, but some people may have increased risk factors and some may have reduced risk factors. So there's no assumption really about where someone's gotten to. We just need to really be sure we're looking at it for each individual. And again, getting their recent medical records so that we can ensure continuity of their care. So in doing all of this then, going through this evaluation process and getting this information on the participant, thinking about what services they might need, thinking about setting those services up, how do we know when the evaluation process is complete? And so it's my pleasure now to turn things back to Richard, and he's going to talk about the approach that he's using to work with his team and see, what they've accomplished through evaluation and where they've gotten to and when they're ready to move forward.
Thanks, Diane. So we just want to reference the form that I created, or our staff created in conjunction with all the ACL information and everything that we've learned throughout the past year. And like Diane was talking about, we're identifying changes in condition to make sure that it's safe for the participants to return. And by changes, we're talking about we have information that we've collected over the past year. I think everybody has a care plan, they just don't really know it. I think care plans that existed in TAS are action plans, quarterlies, the weekly screenings, the daily calls, all that together adds up to basically a care plan. And that is aside from the IPC that we are required to start with the June reassessments fully. And so again, just to reiterate that point, that care plan or the care plans that need to exist aren't capital care plan CEP. It's care plan in how we identify the problems that always existed, how we are remedying them by interventions, and what expected goals that we have to have. And a lot of centers made that through boxes 15 and 16 within the IPC, but again, that's completely separate from the IPC form in general. And again, as reiterating what Diane said, the care plan lives inside the IPC as we know it. So again, just to go back to the form, I think you'll see that this form is very center specific to our center, and it's designed that way because again, it's not the evaluation in totality, but it's the summary of everything that we've been doing within the evaluation. I think everybody's been asking for a form or kind of like a sample of a form. And so I hope this kind of helps a little bit to frame your ideas around what we need to be looking for when we are screening and evaluating participants so that their return to the center is safe. Just to quickly go down the list, we wanted to kind of break it up into physical and cognitive considerations that we have to take into consideration, the social barriers that might exist that might prevent the participant from coming back to the center, and what documentation do we have to support all that. And so the physical cognitive conditions are the significant declines or events that may have happened within the past 6 months that are most relevant to allow or not allow the participant to come back to the center. If there are referrals required to the OT-PT diet, speech therapists, or any other therapists that might be present that are identified by different staff members, then we go ahead and do that. Again, like Diane was saying, some people might start with an evaluation, but they might need a full reassessment because of the complexity of their case. And that's kind of a call for the MDT to make as well. The changes required to existing MDT care plans. Again, we're talking about lowercase care plans, everything that we've been doing, action plans, quarterlies, weekly screenings, and all those touches that we have been doing for the participants. The ability to tolerate congregate services, a minimum of 1 time a week. I think that's a really important measure for us, especially because that's what we're working toward, especially with the participants that are coming in prior to their reauthorization. We want to be able to qualify that. And one thing that we have to take into consideration, of course, is the COVID vaccine, if they have received it, and if we have that documentation on the bottom. on file as well. And so that's something that we have separately within our processes. The social barriers, making sure that the participant understands that they are going to return, and if they have any issues with that or need extra education or training, and just making sure that they have an understanding of the modifications that we're doing. I don't think most centers are doing a 4-hour program. For us ourselves, we're limiting it to a 2-hour program and making sure that all our core services are handled within that time. But the participant has to have an understanding of that, and we need to find out if the participants are willing and or hesitant to return. And so with that, we're always in conversation. What this kind of looks like, this form in practice, is this morning we went through a few participants that we had care plans and everything for. And so we sat down with the MDT and we talked about everything from the driver, the social worker, and the nurse, and having all their input together, being able to fill out this form and really come to a conclusion of, can this participant be evaluated with all these documentations in place, and can we use this form to qualify that they can return or not return? And so this is how we're using this form. Again, additional MDT staff are brought in as needed. Not everybody's going to have every single discipline looking at their care plan. It really depends on need. And again, we want to build off the currently existing care plans that everybody should have. This form won't work if you don't have a care plan. If you don't have things that you are doing within TASK that allows you to do an evaluation, much like Kay was talking about, all that information that we gathered throughout TASK, much like everything that Diane was talking about in terms of what's required to qualify changes, it means you have baseline information that we've had collected over the past year through TASK. And so that's the only way that this form works. And so it's highly individualized for our facility, but we hope that it provides a little bit of context and a little bit of a real world example of what the process of evaluation should look like and what that summarized in one page kind of goes to. And so with that, oh, we have one more slide after. I wanted to kind of lighten the mood a little bit because it gets really content heavy. And this picture isn't the one that I saw yesterday, but I was sitting down and I have a scheduled afternoon yogurt break for myself because my blood sugar gets low around 3 p.m. And I was eating a Go-Gurt, which is a packaged yogurt, and it has a picture on the back because Go-Gurts are marketed to little children. And there was a picture of a bunny holding something up, and it said, "You can do it." And it made me kind of emotional because I was thinking, wow, this bunny really believes in me. And that's how broken and worn down I am throughout the day. And I think most people feel that as program directors, as operators, as staff members. We're so broken down over the past year and a half after everything that we've been through that I really needed this validation from, in this case, Snoopy. And look how furrowed his brow is. He understands me, right? And I think this kind of talks about how we need to collaborate and have confidence. And the confidence isn't about a metaphysical kind of concept of just believe in yourself, but it's really getting down to brass tacks and understanding the standards of participation, what a care plan is, what an assessment is, and what an evaluation is, and being able to support each other and fact check each other, much like we're doing during this training. So this is just to say we don't have all the answers. And again, even that summary form that I just showed you, that's just how we're doing it and how we interpreted it. It's not the gospel, so it might apply differently to different centers, but we are doing it with the goal of moving back to congregate services, again, as our bread and butter and kind of where we belong in the long-term supports and services realm. With that, I'll take it over to Lydia and she'll start the panel.
Okay, thank you, Richard. I will say we can do it. I just love the yogurt. I'll never look at yogurts the same way again. We're all looking for those little signs of encouragement. So I want to welcome our panel back to turn on their cameras and join Richard and me, and then we're going to dig into some of the great questions that have been coming in. A lot have been answered. I want to thank Denise and Lois, Lena for tackling questions on the fly as they came in, and then I've selected some that I want to ask of the panel. So are you guys ready to go? All right. First one, there were quite a few on kind of the whole assessment, reassessment, timing, and all of that. But before we get to those, I want to go to a question about vaccination. So Anushik was wondering if you are bringing unvaccinated participants in and how you're handling that for evaluation or for services. So who wants to start that off?
I can start that off. We're currently programming to start bringing in vaccinated participants to our facility, and we'll start that way. We haven't had specific guidance in terms of how it differentiates vaccinated and unvaccinated participants, but it's just a safety measure. And for everybody to be as safe as possible, the logical conclusion at this point for our facility is to start serving the vaccinated participants first, and that's how we're scheduling it. Again, that's not to cut out the unvaccinated participants because we still have the alternative services in place. And again, that's going to change once the guidance does come out, but at least how we interpret the current rules and kind of regulations that they exist, and with the spectrum of services that we can provide, and with the added fact that we have to safely return. The only way to safely return is to have the safest people return first as well. And that's not to be discriminatory. It's more of a triage and kind of a prioritization of where we need to start.
And I think for me, what that says is too, you're sort of having a bit of a soft opening where you're sort of, you've got to test out some processes and timing and all of that. So kind of go with, with a graduated approach to folks where you do know you have to be extra careful. So that makes a lot of sense, Richard. Any, Lena or Kay or Lois, do you have any other response or want to add on to that in any way? Or we'll go on to the next question. Lena?
This is Lena. So good morning, everybody. We are bringing in participants despite vaccination status on an individual basis for reassessments and evaluations. The staff is vaccinated, and that's why we feel comfortable doing that, because it is individual. But when we do start in-center congregate services, we will be taking a similar approach as Richard's, and it will be based on triaging and need of the participants as well as the safety.
Okay, thank you. There were a couple of questions that came in about how to address participants who have been enrolled during TAS, so they never had a complete in-center MDT evaluation. So the first question is kind of how are you handling that, and are they being are you bringing in a full MDT for them now? Are you evaluating them, or are you conducting a full MDT even if their retar may not be due? So just sort of timing for those people that enrolled during TAS, if someone would like to take that one on.
Go ahead, Kay.
I'm sorry. So just as I think it's important to evaluate what your process was during when you were enrolling participants during the TAS period. Some centers did bring on their therapists on board for those assessment purposes, and others did not. So I think the first step is to kind of look into what information you did have when you were assessing the initial participants and they were first being enrolled, and then to go from there and to use a lot of the information that you had. I think a good practice is to see what the circumstances are of that particular participant. If they're able to come into the center for an evaluation and you're able to schedule them to come in on a day when the full MDT is available, I think as a best practice, just in terms of logistics, would be very, very helpful. But again, I think the key is to consider what the participants' individual needs are, and to base it that way, because this is still at least, and I think in a lot of centers this month especially is focused on a lot of the reassessments that are due July 1st, as well as getting the evaluations for participants who really need in-center services as soon as possible, whereas others are still being served through remote and doorstep services, which is still a really vital portion of the TAS program during the hybrid process. For our center, for example, because we did have our therapists on board, we did have our participants who were initials evaluated assessed that way, and we're bringing them for an in-person look to make sure all of the information that we gathered is accurate and to add to it. So I'll pass it along to Lena now.
Thank you, Kay. We have a similar approach for participants enrolled during tasks. If they are up for reassessment, yes, the entire MDT, which includes OT, PT, dietitian, pharmacist, they are all taking a look at the participant and updating the care plans for reassessment. For evaluations, we are also including the OT, PT as well, mainly because if they are getting ready for in-center congregate services, that exercise component, the PT and OT component, is going to be something that we weren't providing to them while they were at home. Our center had stopped PT/OT services. We were not doing remote PT and OT. We were outsourcing to home health. And so bringing them back in, we will be giving PT and OT. So for our center, it is essential for the PT and OT to also be evaluating the participants whose TARS are not due for reassessment.
Okay, that's good. So kind of on the same theme of quarterlies, are all of you conducting regular routine quarterlies now in person? Or are you doing, is it a mix still of remote and in-center quarterlies? Lois, how are you handling those?
For us, it's a combination. We're doing as many in person as we can, but we're doing some of them we're doing remotely still. We're doing as many as we can.
Kay and Lena, Richard, let's just go down the row. How about you, Kay? Combo?
We're in a similar boat with Lois. We're also doing a mix. And part of it is because we do want to be responsible with how many participants we're bringing into the center at a time, and because the restrictions are still into place. I'm sure, you know, in an ideal world, we don't have restrictions. We just are able to bring participants back. But because we do have to be very thoughtful about scheduling, transportation, and how many participants are able to be really seen in a meaningful way by our staff during the hours in which our program is being run, we just can't, you know, realistically bring everybody in who's due for quarterly this month or the prior month or whatnot. So it's more of just this a combination of factors, including scheduling and if the participant is ready and comfortable enough to come into the center. So we're trying to keep it very person-centered in that way.
Before you answer, Lena and Richard, how you're doing things, I want to add another little twist to this, because we had another question about if the OT, PT, speech, those therapists, clinical staff haven't been seeing people during tasks, and their quarterly is due, are you just using all of the staff to conduct the quarterly who have been working with that person? Or are you now, because Lena, Kay, you sort of alluded to that, are you bringing in the therapists even though they have not been actively working with them during tasks? So Lena, if you could answer both of those parts of that question, and then Richard.
For quarterlies, the approach that we're taking is, for the most part, they're being conducted remotely unless the participants are ready to come back to in-center services. I'm taking that opportunity and doing the quarterly as an evaluation. And so we are updating the care plans, not the entire IPC, but just the care plans, and using that as their form of evaluation to kind of get them. So kind of killing two birds with one stone. And what we have started doing in June is the entire MDT is doing quarterlies, regardless if the participant is ready for in-center congregate services or it's just a regular quarterly. And even though we were not providing OT-PT services during remotely, the OT and the PT are doing quarterlies, and they're using the existing care plans as a baseline to kind of as a starting point, because we view quarterlies as the 3-month reassessment, where you are evaluating your care plans and whether the needs have been met, if you need to amend the care plans, etc. So we are going ahead with the entire MDT for the quarterlies, because that will set the stage when they are due for reassessment. Because when you come at that 6-month reassessment, you're going to be presented with the same issue. Well, we weren't providing OTPT services for the past year, so they need to start somewhere. And so I figured might as well start with the quarterly, so that when they are due for reassessment, they'll have an even more updated place to start.
Okay, Richard. Thank you, Lena.
Yeah, we're very similar to Lena's situation, to where we were providing OT and PT services intermittently. When the cases got really bad, we had to pause it for a while because we didn't want the therapist to come to our facility and just kind of limiting all that. But I think because of that, we needed to start somewhere. And throughout this process, we've utilized the teamwork between the therapists and also the nurses to be able to be kind of like the point of reference in terms of identifying the issues that may need referral to the OT and PT. And so most of our evaluations are based and kind of started in person, because we have been doing everything doorstep. Including having nurses and social workers go out. But I think that's how we want to structure everything, right? The evaluations, reassessments, and also the quarterlies. We start at trying as much as possible to do it in person in a safe way, and then resorting to kind of remote services as needed. I think it would be bad form to make everything remote just as a standard, as default, and then do it the other way around.
Okay, great. That's really helpful. That covered quite a few of the questions that came in. Vic is asking, are you guys getting history and physicals for your evaluation prior to people coming in? Again, sort of uncharted terrain here. There's no specific guidance on this, but what are you all doing? So start with Lois again.
Yeah, we're sending off a fax and asking for an updated H&P for everybody coming in. Just, we want to make sure that we know what their, if they have any changes in meds. I mean, we've been keeping pretty good track of that, but we want it directly from the physician when we can get that. And we've had pretty good luck in getting those back from the primary care physicians.
Okay, that's great. How about you, Kay, Lena, Richard?
Yeah, we've been consistently getting our H&Ps throughout the entire task period. And so it's really business as usual in that sense, because whenever a participant was due for reassessment, we followed our normal processes from traditional CBAS and getting our H&Ps. So it's a lot of the same processes that have continued throughout. And we've been working to get as many medical records as possible, again, throughout. And so there haven't been too many changes in that realm during the task period.
So are you linking that also to the evaluation? So this is somebody that's not on a regular quarterly or retar. Are you doing that also as part of just bringing them in for the evaluation process too?
So it depends. So it would, depending on when we most recently got their H&P. In some cases, we had just gotten an updated H&P, so it would really be repetitive. It would be the same information if we just got the H&P a few weeks prior. So it really depends on how the scheduling is working out.
Okay, that's great. Lena, how about you? And then Richard.
We also never stopped sending and receiving med psych updates or H&Ps.
Okay.
And how we always send it right before the TARS during reassessment. So usually it's consistent when the reassessments are due. Now for evaluations, like Kay said, we would just see when was the last time we received a med psych or an H&P from the physician, and we would go off of that. But it wouldn't determine, I wouldn't hold off bringing a participant in for reassessment or evaluation if I don't have an updated H&P or med psych, because we actually, unlike Lois, we don't have much luck with receiving those, and we have to kind of hound the physicians. And so what we would do is our reassessments, evaluations, determine the medications, and then contact the PCP for verification.
Okay. Richard, how about you?
Sure. Yeah, we're similar to Kay in that it was always our normal process, but I don't think that might help centers that don't have the H&Ps as their normal processes. And I think 2105, I believe the ACL clarifies that for people that were enrolled during TAS, that they need to have the H&P prior to returning to congregate services. And so I think that's the baseline that we want to have. I think everybody at least has, a standard H&P because most care plans require that when you're submitting for screening or when you're submitting to have a new participant. But again, if it's part of your normal process, and for us, it helps us because it's part of our evaluation process so that we get the most data possible to have a current, not just care plan, but health information on the participant. But I think it would be best practice to get updated history and physicals. For us, our criteria is if it's valid within the past 6 months, then we usually are able to use that information, but it might vary center by center. But I think the regulation is, or the requirement is in 2105 in one of the FAQs.
Okay, so I want to shift gears just a little bit now. We've had several questions come in about vaccinations again, but this time relative to staff. And we had been querying our audience, as you recall, over several webinars. We haven't done it the last two, about how things are going for staff and participants, vaccination rates. And I know just from talking to some of you, for example, you were very proud that you were at 100% staff vaccinated, but then something changes. Someone leaves, someone comes in. So we have several questions coming in around how you are working with staff who are unable or are not ready to receive a vaccination. And have you given some thought to what that might look like when you start bringing more participants in? So any of you in that situation right now?
We currently are, I guess, in a way unresolved in that we still have one staff member that hasn't gotten their vaccination. And so we just make sure that that part or that staff member isn't present or in the same room or anybody when we have participants coming on a one-on-one basis right now. I still haven't completely figured out how I'm going to reconcile that when we get the final guidance from CDPH in whatever form it may look like. And so I feel confident in saying that it's not a problem that I have solved yet, because I think a lot of people are in that position. And then that we are passively, with the kind of vaccine slide that we went back to, really making it as accommodating as possible to have that staff member look into getting a vaccine, whether it's like 1 block away from our work or on their day off. I'll drive you if I have to, kind of thing. But I think, again, it's not an easy question to answer, and I don't think there's a silver bullet to kind of getting everybody to 100% vaccination, because by far and large, that's not going to happen for a lot of places, and it's going to be an operational kind of thing that you have to figure out once you start to reopen.
Yeah, and we've been taught over these times from some very expert, smart people that it's all about masking, distancing, and ventilation, right? Those are the 3 things that we all have to be attentive to, and working all 3 of those to their maximum is very effective. But even if you can maximize 2 out of the 3, that's pretty good. And we know masks are super important. So yeah, thinking through then how to handle PPE and all that. Yeah, we've got a little time to figure it out. We'll get the guidance. Hopefully that will help us all. But Kay or Lena, Lois, do you have anything you'd like to add to what Richard has just said, or are you kind of in the same spot?
No, I would like to add to it, just because our situation is quite different. I feel like, seems like every time our situation is quite different. At this moment, we're fortunate that all of our staff are vaccinated, but I expect that could change, potentially change at some point. But our parent organization, because we provide community services in a number of different ways, has decided that the responsible thing is to mandate that all of our staff be vaccinated. And so they've consulted with the lawyers, and they have made the decision as an agency overall that that all staff will need to be vaccinated. So just putting it, because I'm seeing some questions coming in saying that we can't demand vaccination.
You can.
You can, right? Yeah. I mean, you must provide accommodations for people who, for health reasons or valid religious reasons, can't be vaccinated. You must accommodate with that, but you can. I believe that you can now require vaccination.
Yeah, that was just adjudicated in a court case. So,
Yeah.
so that it just gets to be really personal and very individualized, center by center, as to what your rules may be. So I do have a comment from Karina, and I know in the Department of Social Services guidance, they are still requiring testing of staff, 25% of staff weekly to be tested for COVID. So of course, we haven't talked about testing in a long time, but that is certainly something in your toolkit also for addressing participants or staff who aren't vaccinated. So those were some of the questions that came in around vaccination. So I would like to just ask, we've got about 8 more minutes for questions. So if any of you out there have some burning questions that haven't been addressed in writing already, or you've just thought of something, this would be the time to pop it into the question box. There was one more from Maria about vaccinations. Can we ask for proof of vaccination from our participants and keep them in file? And I do believe the answer to that is yes. Are any of you just making copies of the vaccination cards? I know the governor has announced that the state is working on a electronic vaccination record of some sort. So what are you guys doing relative to participant vaccination records? Can we just do a real quick round robin on that, Richard?
Sure. Yeah, when we started back in February, once we knew that we scheduled the participant, or once they were finished with their vaccines, we went out, because we were doing doorsteps, and took a picture and made sure that we filed them within each charts. And then we also did a aggregate of that and then sent it to the corresponding PCP so that they had the information, just as best practice, so that everybody's on the same page of who needs to get vaccinated and not. And that helps us keep track of, again, who's vaccinated and not. And if we have to follow up on someone, then we do that. But I think it's kind of a slow process to do that, because it's very hard. And already some people have lost it. And so the pictures that we had from beforehand, it's evidence that they got vaccinated. And so it's really helpful to have that.
Right. Lena and Kay and Lois.
We're also making copies of their vaccination cards and filing it in their participant medical records.
Yeah, similarly, we're trying to get them whenever we can. Like Richard was saying, sometimes it's already been lost, or it's just it lost into the ether, I don't know, but we are trying to get them as much as we can. And at the very least, we do have an internal log that we've been keeping at the center throughout when vaccinations first started, which has actually been really helpful, making and providing reminders for our participants, especially when they need to go in for their second dose, for any participant who was getting a two-dose vaccination. So again, it's just keeping in with all information can be useful in the future. We've also been keeping track of the brand. If we don't know if that'll ever be useful, whether it's a Pfizer, J&J, or if it's a Moderna, but that was just information that we were able to get at the time. So we thought, why not? We'll just keep track and see what happens.
Okay.
Yeah, I'll say we're keeping paper copies as well, and then we're also putting a quick note in the front page of our TurboTAR, our electronic health record. There's a little box for notes, and so we're making sure that we have that noted, so you can just look at the participant's record and see quickly that they're vaccinated.
We just had a question come in about, can you require participants to be vaccinated? And the answer is no. So staff, yes, you're an employer, you're a private business. Participants have a right to free choice. And so the best thing is education, support, really listening deeply about whether it's a staff member or participant as to what their questions and concerns are, as I've always said. And I didn't come up with this little saying, but I learned it from someone who provided a webinar on this very subject, which is no does not mean never. And some people are just a slow yes. So you want to be sure that you're relying on really reliable, factual sources of information, and not give up, but be open and supportive. So thank you for asking that question.
Could I just add to that? Just
Yeah,
quick.
please, Lois.
If I could just add, we had a couple of, so all of our staff and all of our participants became vaccinated before we were talking about any requirement for it. So, but we had a number of staff and participants both who were very hesitant, and we spent a lot of time in doing education and encouragement, and so I'm not sure that everybody can get there 100% that way, but I got way further at the center than I expected to. So.
Okay. Very good. Well, we're just about at time here, so I think we're going to excuse our panel. I want to thank you all. It has just been a pleasure working with all of you during all these months. I know we have a lot of hard work ahead, but thank you for taking the time away from your center, your families, to be with us every weekend today. So thanks, everybody. Appreciate that. And thanks again to you, Jill and Denise behind the scenes, helping out with questions. I think we got almost all of them answered directly. So go ahead, Danielle, and we can move on now to our next slide. I have added here a link to the public health order, and please, in the PowerPoint that you have, there are clickable links during the segment that Jill provided to us. Those 4 slides all have clickable links so you can easily access the information that it's referring to. And then here's a copy again of the June 11th public health order, which was effective yesterday. These are familiar ACLs and ASCs from Department of Social Services. And then I found this article in the New York Times, so I hope you can get past the paywall, on reopening office space. It's a lengthy article, but it's very thorough and very, very good things to think about for those of you who are in buildings that haven't been utilized very much. So I commend these to you. Next slide. And calendar, lots of great stuff coming up, everybody. Today at 1 o'clock, the Department of Social Services is hosting one of their COVID-19 related webinars, and this one is going to be a little bit different. It's 2 hours. They've got some fantastic experts on hand, including Dr. Louise Aronson, who's a regular on these webinars, who's the author of Elderhood and is at UCSF. There's another UCSF doctor. Anyway, some fantastic people to talk about regaining what was lost physically, mentally, and socially. So this is not just for ADPs. I think all of us can benefit from tuning in. So if you have time, click on that pin or go on Google pin 2129 ASC, and that'll give you the Zoom link to register for that. Actually, I think it's just a direct. I don't even think you have to register ahead of time. And then tomorrow afternoon, we've got the CDA quarterly update webinar. So you can register by clicking here or going to the CDA website or looking in the CDA newsletter that just came out, I think last week. And then our next web talk, I'm very excited about. Susie Gruber, who's a very popular presenter, is going to help us think through our COVID challenges and ways to support mental health and our teams and participants, especially thinking through the lens of trauma. And I think you all will really enjoy here. We're going to try to make it really experiential and really relevant to your everyday work. So hope you can join us for that. Right now, tentatively, we've got July 21 to talk about fire, smoke, heat, power shutoff emergencies. So the team is working to pull together some resources and experts to give you the latest on this. It's starting already, everybody, so be aware and ready. Then August 4th and 18th, those are our dates, but we don't have it pinned down yet. We'd like to do something on hiring and retention of staff, and then something in August. I think the 18th will be a celebration of congregation celebration. Remember our innovation celebration. So we'll start hearing from you all about how things are going as you bring people back to the center for group services. So I think it's a really great lineup. if you've got other ideas, please put them in your survey. And the last slide for today as we close up. Not really giving you a quote this week, but this caught my eye, I think because it's plants and trees, but also it was just such a simple message and it really hit me. It's kind of like what we've been discussing during this whole COVID time, and it seems like a mantra for us as we think about evaluating and assessing our participants, and as we're meeting and talking with our teams. You meet people where they are at the moment, right? And then you look for the strengths to build on as you apply your listening skills in your use of open-ended questions, as Diane described to us today. And then you do what you can. You do the best you can. You move forward with your teams and participants. You guys are partners and you're rediscovering why you're all in this together and why you're all eager to get back together in this crazy business that we call adult day services. And I just know I've said this before and I think about it all the time. We've just been together through this incredible once in a lifetime experience, and we got through it by doing what we can, right? That's all we can do. Can't do more, you can't do less. You can just do what you can, do the best you can do. So just like that yogurt container spoke to Richard, this spoke to me, and I share it with you all. And I'm beginning to imagine the excitement you're going to begin to feel as you bring people back to the center, your staff, your participants in this place we care so much about, and the people we care so much about that get together in adult day services. So thanks everyone for listening. Stay safe, stay calm, stay cool, and we'll see you in about 3 weeks for our next web talk. So thanks everybody for being here. Thanks again to our panel. Have a great rest of the day.